Welcome to AETCM, the emergency medicine channel. Today, I'll be presenting a case of 18-year-old male who presented to ER with complaints of, with history of fall in a canal. He slipped and fell into a canal, and following that he fell forward facing and had sustained trauma to abdomen. Now he came with complaints of abdominal pain and 2 episodes of vomiting. On initial 10-second assessment, the patient was conscious and oriented and obeying commands. The airway was patent, breathing, air entry was bilaterally equal, no added sounds, there was no any tenderness.
What else you want to check in a trauma patient along with airway?
Airway, we have to check for any secretions or any gurgling sounds, stridor or any foreign body.
Any bleeding?
Bleeding.
Then with the airway, something else?
C-spine tenderness should also be checked. There was no C-spine tenderness. And breathing, there was air entry was bilaterally equal, no added sounds. There's no tenderness on the chest, and saturation was 98% with a respiratory rate of 22 per minute. Circulation pulse rate was 96 per minute with a BP.
Breathing, you need to look for the chest movements also. Any penetrating injuries in the chest?
No aberrations or external injuries. Chest movements were equal, both sides. Circulation pulse rate was 96 per minute with BP of 96/60. 2 18-gauge IV cannula was placed, and disability GCS was.
Then circulation, one more thing.
Capillary refilling time was 2 seconds.
And you also mention about any active bleeding.
No other active bleeding. Disability wise, GCS was 15 out of 15 with pupils equal and reacting to light. Patient was moving all 4 limbs. Exposure wise, temperature was 98 and GRBS of 112. There were aberration marks over the right hypochondria.
Okay. So this patient, what is the significance of temperature in this patient?
Temperature, the patient can go into hypothermia if there is ongoing bleeding.
Okay. So this patient especially has a history of fall into the canal. So we need to suspect drowning also along with that. So drowning along with hypothermia. Okay.
And there was also aberration on left forearm and right hand. Okay. The adjuncts of primary survey, we did a blood gas, VBG showed pH of 7.41 with bicarb of 22 and lactate of 1.8. And base excess was -1. EFAST was done, which was positive. There was subhepatic and perisplenic free fluid. Coming to secondary assessment, the patient has no allergic to any medications, and he has no other past history or not on any medications. And the patient was parked the car by the side, and he walked to the side for passing urine. But that time, while returning back, he couldn't see, and he slipped and fell into the canal. And he fell facing forwards. He fell, and no traumatic head was there. He mainly hit the chest and abdomen part, and he complained of pain mostly in the right hypochondrium region.
He fell into the water?
There was no water, it was empty. And right hypochondrium pain he was complaining of, and he had on the way 2 episodes of vomiting also. And on examination wise also.
He had a fall, and following which a right hypochondrial pain. So what will you suspect? What injury will you suspect?
We have to suspect a hepatic injury. Then we have to suspect lung injury or rib fractures, lower rib fractures. You have to suspect other associated vascular injuries also related, hepatic vein, portal vein, extrahepatic portal vein.
Okay. Then, so we are suspecting a blunt injury to the abdomen. So what is the most common organ which will get injured in a blunt injury?
Blunt injury, most common is liver.
Liver and spleen also. Spleen is having a tendency to rupture fast. Okay. Whereas in case of penetrating
spleen, bowel.
Penetrating bowel, liver is more common in the upper abdomen, liver and bowel also. Bowel is more common in blast injuries or gunshot injuries. Bowel is more common. So penetrating liver is more common, blunt spleen is more common.
Okay, then on examination, upper abdomen examination showed it was soft, but he has tenderness in the right hypochondrium with Gardi.
Any penetrating injuries?
No penetrating, only aberration marks were present. Scattered Grace aberrations were present over the right hypochondria and epigastric region. And Coming to
Along with that, if there is any hemoperitoneum, this patient is having an EFAS positive. That means a little bit of hemoperitoneum is
Yes,
there.
sir.
So we can see the Gray Turner sign and the Cullen sign if there is hemoperitoneum. Not only in pancreatitis, we will be seeing in these conditions also. And you need to also examine the pelvis also, pelvis and external genitalia in this patient, because it is in the case of abdominal trauma. Okay.
No other external injuries were present for the patient. Coming to investigations, HB was checked. It was initially
Fast was positive in the
Fast
right
was positive,
hypochondrium. What about the extended fast?
extended fast was negative. No, it was fine. Lungs, there was no lung sliding was normal, and no pericardial effusion.
Okay.
Only in this spleen and hepatic region there was free fluid. So we took investigations. HB was 12, and also the OTPTs were elevated. 90 OT with STPT 205. Bilirubin was also elevated. Total bilirubin 1.99, direct 0.49, and CCT abdomen, because the patient was stable, we further investigated.
So main thing in the ER, we will check for the check the vitals and classify this patients based on the shock. So what shock is this? What classification we can classify him?
Maybe class 1.
Class 1 only. There is no tachycardia, no hypertension, nothing. Okay. So he was in class 1 shock. He is stable only. VBG wise, we check for acidosis, and base deficit we have checked. Base deficit is also less than -2.
-2. And
so say stable, that's why we plan for CCT. Okay.
CCT abdomen was planned, and in that there is features suggestive of American Association for this surgery of trauma grading. AST class grade 2 liver injury was there, and there was also subhepatic and perisplenic free fluid. And since it was grade 2 liver injury, we gave it to gastrosurgery side, and they planned for non-operative management, conservative measures. So he was started on analgesics, PCM, and SOS tramadol was started, and also further monitoring was done, observation was done, and vitals monitoring was regularly done.
Okay. So how will you classify liver injury?
So liver injury, based on American Association for the Surgery of Trauma, there are 4 grades. First grade, based on 2 things mainly, they look into subcapsular hematoma and or intraparenchymal hematoma and parenchymal laceration. These 3 aspects. Subcapsular hematoma less than 10% with parenchymal laceration less than 1 centimeter depth. It will be classified as 1. It will be classified as 2 if there is 10 to 50% subcapsular hematoma, and intraparenchymal hematoma less than 10 centimeter. So in second one, intraparenchymal hematoma gets added, and laceration will come from 1 to 3 centimeter. Then third one, it will be more than 50% subcapsular hematoma, and or it can also be ruptured subcapsular hematoma or parenchymal hematoma. If it is ruptured also, it will be in third. And if there is an intraparenchymal laceration more than 3 centimeter depth also, it is 3. Or if any injury in the presence of a liver vascular injury or active bleeding within the parenchyma also will come under 3. Then if there is parenchymal disruption, around 25 to 75% of hepatic lobe is gone, then it will be 4, with active bleeding also extending beyond liver parenchyma into the peritoneum. So within the parenchyma it will be 3, beyond parenchyma it will be 4. Fifth grade will be if there is parenchymal disruption greater than 75% of hepatic lobe, with other juxtahepatic venous involvement injury, or any retrohepatic vena cava involvement or central major hepatic veins involved. Then 5. Previously 6 was there, complete avulsion, but now it is not useful because the patient will be more moribund patient.
Okay, so when will you plan surgery in this patient, in a liver laceration? When all will we do surgery?
Usually for low grade injuries, mostly it will be managed with non-operative management, grade 1, 2, 3. If it is 4 and 5, mostly
that
the patient vascular involvement is there. So the patient will require either angiography with embolization or surgery will be required. Or in case of peritonitis and all, if there is hemorrhagic instability, definitely you have to take up for
these
surgery.
are the other indications for doing a laparotomy. That is one is
in that case, we can't even wait for CT. You have to directly take after EFAST If it is positive with hemodynamic instability, you have to take up for surgery, laparotomy, and we have to check.
Okay, so other indications of surgery,
Then,
one is this thing.
Hemodynamic instability. Then if there is any peritonitis features or if there is any systemic inflammatory response like symptoms like ileus, tachycardia or oliguria, decreased urine output. Then if there is any gunshot injury also, we have to open up the abdomen to see for any other intra-abdominal.
Penetrating injuries.
Any other injuries can also be there. So that also indication.
Then evisceration. If any abdominal organs are out, then also that is an indication. Any features of peritonitis or any features of this thing, hemoperitoneum. Hemoperitoneum and pneumoperitoneum also. Hemoperitoneum based on the injury, but pneumoperitoneum definitely will require surgical management. Okay.
Yeah, and also in case if we for controlling the bleeding, if we are planning for angiography and embolization post procedure, there may be some amount of hepatic necrosis. If that is also there, then also that necrosis lobectomy has to be done. Further also you have to.
Anything else?
Then operative management, depending on how much bleeding is there, we can divide minor and major bleeding. Minor bleeding, we can just open up, do electrocautery or argon beam or topical hemostatic agents. Major bleeding, we have to open up and do packing and resuscitation has to be done. If it is uncontrolled, we have to do further Pringle maneuver and selective vessel ligations and all. If it is controlled bleeding, then further we can do angiography and check for any vessel and do embolizations. Then delayed laparotomy, interval laparotomy can also be done later. It can be done for debridement or if any definitive debridement or resection is required.
Okay. So in a patient presenting to ER with trauma, how all will you control the bleeding? There are two types of bleeding. One is compressible, one is non-compressible. This is a non-compressible type of bleeding. So if this is a compressible bleeding, we can, what all things can be done? We can give direct compression. Tourniquet can be used. If you are using tourniquet, how often will you release it? Like if it is a limb injury and all. A tourniquet will be applied tight in order to prevent bleeding. So if you are suppose you are applying tourniquet or any binder or something, how often will you release it? Every 45 minutes to prevent the ischemia of the distal area. Okay. So that is compressible type of bleeding. Then non-compressible bleeding. This is a non-compressible bleeding. What are the other non-compressible bleeding?
Splenic, other
any abdominal injury is non-compressible. Then hemothorax,
cardiac
tamponade. These are non-compressible type of bleeding. Even the pelvic bleeding can be controlled with pelvic binder. Okay. So, so these are the types of bleeding. So, what all things will you check? So, this is a case of isolated case of hemoperitoneum. So, we'll stick on to that. So, what all things you will be monitoring? Initially, we have classified the patient based on the type of shock. So, this is a class 1 shock based on the presence of the base deficit and also the patient's hemodynamics. We will be classifying based on the shock. So, suppose this patient is in shock, hemorrhagic shock. What will you do?
Depending if now the recent guideline is to do a balanced resuscitation. So we'll keep the we should not compromise the organ and tissue perfusion, but at the same time we should keep the BP at a lower than normal limit to reduce further bleeding. So depending on the class of shock, we can do the management accordingly, aggressive required or not.
So we are planning on balanced resuscitation. So what do you mean by that?
Balanced resuscitation, we have to match the organ and tissue perfusion and also keep the BP limit below the normal limit.
So how will you know whether the tissue perfusion is there?
We have to check for urine output. Can be checked at least minimum. We have to keep 0.5 ml per kg per hour. Urine output can be kept and then IVC can also be checked for.
IVC will be mostly collapsible in case of a patient with this thing, hypovolemia. So in this patients, our target is if 3 targets are there. One is balanced resuscitation. Next is hemostatic resuscitation. Third is damage control surgery. So first we will be looking at the balanced resuscitation. So balanced resuscitation is to prevent What are you trying to prevent in balance resuscitation?
Unnecessarily
Unnecessarily we are
hemorrhage.
not increasing the BP, or unnecessarily we are not flooding the patient with more amount of fluid. Why we are doing that?
To prevent excessive bleeding.
To prevent bleeding, one thing is there. Then, if at all anywhere there is a clot formation, we don't want
dislodge the
that clot to pop out. Then, dilution of the coagulopathy, and giving these fluids itself can cause an inflammatory cascade, because it is from an external source, no, so that can cause an inflammatory cascade in the body. That can be prevented. And this, whenever you get IV fluid, we will have a tendency for hypothermia. Patient will go into cold. So we are trying to prevent the lethal triad. What is lethal triad?
Lethal triad: hypothermia, acidosis, and coagulopathy.
So that's why we are planning on balanced resuscitation. When all will you not do balanced resuscitation?
There is a class 3 to 4, class 4 shock, and all. We'll have to aggressively manage, minimally manage with blood products.
All cases you can do a balanced resuscitation in all injuries except for brain injury, because if we are reducing a balanced resuscitation means we will be keeping a low MAP in order to why a low MAP? Because we don't want unnecessary, these things should be prevented. So low MAP in the sense, in a case of septic shock and all, you will be keeping a MAP of 65. This patients will be keeping a MAP between 50 to 60 only. That means a systolic BP more than 70. So BP will be targeted more than 70, MAP will be 50 to 60. This cannot be done in case of a patient who is also having IC bleed, because if you are targeting a very low MAP, in such cases what will get affected?
ICP pressure will be more,
cerebral perfusion will be
decrease.
affected. So that's why we are not doing it in brain injury. Otherwise, in abdominal injury, 50 to 60 MAP is only required for the other abdominal organs to get perfused. So increasing the BP is not of much use. Provided that this patient is not having any other coronary artery disease or hypertension or anything that can affect the balance resuscitation. And whenever you are planning this balance resuscitation also, note that this patient is not having a high lactate, or urine output is getting compromised, or the patient is worsening. And how long will you plan on this balance resuscitation? So this, you are getting a patient with abdominal trauma, hemoperitoneum is there, BP is only 80-40 somewhere. So you are happy with that BP because we are not unnecessarily giving fluids or anything. How long will you entertain this?
No, we have to, as early as possible, we have to take up for active bleeding. Surgery. Surgical management of the bleeding has to be.
So it is balance resuscitation is only a bridging therapy. It is not a treatment of choice. So if this is only a bridging therapy, immediately the patient should be shifted to the OT. So maximum time up to which balance resuscitation can be practiced is only 90 minutes. More than 90 minutes, if it is going more than 120 minutes, the organs will go into necrosis. So maximum time is 90 minutes. Okay. That is balance resuscitation in abdomen. Okay. Then next comes hemostatic resuscitation. So suppose when all will you give blood products in a patient with hemorrhagic shock?
That was a class 4 shock. We can give low ratio. In a low ratio, we can give blood products.
So if the patient is having hypertension, with this patient's BP is only some systolic BP is only around 65. What will you give first? You know there is hemoperitoneum. BP is very low. What will you give first?
Equal ratios you have to give PRBC.
Yeah, first you will have to give fluids. How much fluid will you give?
500 ml.
You can give 1 to 2 liter of fluids, 20 ml per kg in children, and in adults you can give 1 to 2 liter of fluids. Okay, restrict to 20 ml per kg so that you can give only maximum 1 liter like that. Then after that you reassess the BP. Along with that you can give tranexamic acid to prevent bleeding. Okay. Then the next option is going for blood products. Okay. So in hemostatic resuscitation, blood products, when all will you plan on transfusing? What all things will you transfuse?
We'll transfuse PRBC, platelets, and FFP. 1:1:1 ratio.
1:1:1 ratio. Why that ratio is kept?
Prevent massive MTP. Prevent coagulopathy.
So we want to give the PRBC, platelet, and FFP so that all the factors will be there. Okay, so 1:1:1 protocol we need to follow, and that will be followed only after fluid resuscitation. And still, if the BP is low, then only we will be planning on doing that. Okay. Otherwise, if the patient is not having this hypotension, then also we will be practicing this hemostatic resuscitation. That means whenever the patient's HB is less than 7, as we do for all cases, whenever the HB is less than 7, we need to transfuse. Then if the platelet is going less than 50,000, then also you will have to transfuse. Okay. What is massive transfusion protocol?
Massive transfusion protocol, you have to give the same ratio around 4 units of PRBC, platelets, and FFP. If it exceeds more than that, then you have to activate MTP.
That means if the patient is requiring more than 10 units in 24 hours or in 6 hours, within 6 hours, or if the patient requires more than 4 units of PRBC in 1 hour, that is called as massive transfusion protocol. Okay. Okay, so these are the main things in ER. Okay. We have already discussed about the fluid resuscitation, initial fluid resuscitation. So I told the map is around 65, we are giving fluids. Then what all response will you check? What are the 3 types of responders?
We have the rapid responders, transient, and minimal or no responders. Rapid responders, they will respond quickly to the initial bolus, and there won't be any signs of decreased tissue perfusion or oxygenation.
They will be mostly in class 1 or class 2 shock.
1 liter bolus itself, they will improve. But transient responders, initially they will respond to the initial bolus, but once we make it to maintenance therapy, they will not be able to achieve the BP because there will be ongoing blood loss or there is inadequate resuscitation. Then in minimal or no response, they will not respond to crystalloids or blood. They will require surgical interventions or any angiography embolization.
Okay, so that means that if, rapid responders will have only less than 15% of the blood loss.
Blood loss, class 1 mostly.
Transient responders 15
Class
to
2 to
40%, and more than 40% in non-responders. Okay. Okay, so we have discussed about balance resuscitation, hemostatic resuscitation. Next is damage control surgery. What is that damage control surgery?
Manage that stopping the bleeding site with any
damage control resuscitation is planned in case of severe trauma like this. So that is usually planned if there is any indication for MTP or this resuscitation is required. Okay, so what are the phases of damage control surgery? First phase is phase 0. Phase 0 we will be doing whatever necessary for the patient, like an IV cannulation or intubation, whatever is required, and that is the rapid stabilization. Patient won't be getting stabilized in the ER, only patient will be getting stabilized only in the OT when the surgery, damage control surgery is done. So first is the initial resuscitation in ER, next is the surgical repair, that is phase 1. Phase 1 is the immediate surgical repair. Then phase 2 is stabilization in the ICU, and stage 3 is definitory repair. And one more stage is there, stage 4, that is the reconstructive, any surgeries or anything required, that is stage 4. Okay. Okay, so if a patient is coming to ER with a history of trauma, what all, and with hypertension, what all things will you suspect? Like what might be the cause of hypertension in a patient with trauma?
The hemorrhagic shock can be there.
Hemorrhagic shock is the most
Then
common
cardiogenic
cause.
shock due to cardiac tamponade, or the shock due to tension pneumothorax.
That is obstructive shock.
Obstructive shock.
Obstructive shock is because of the reduced flow.
blood flow.
So that can be because of tension pneumothorax
and
or cardiac
tamponade.
tamponade.
Obstructive shock.
Then cardiac causes any direct blunt injuries to the heart or anything. Okay.
Then neurogenic shock if there is any spinal injury.
Okay. And late.
Septic shock is a
Septic shock
secondary
also.
infection.
Okay. So then when a patient with trauma goes into cardiac arrest, what all can be the cause of cardiac arrest?
Tension pneumothorax, cardiac tamponade, then hypovolemic cause of cardiac arrest, hemorrhage,
Hypoxia.
acidosis,
Acidosis
Severe
because of the
secondary
reduced
hemorrhage.
perfusion and lactic acidosis.
cirrhosis.
Hyperkalemia, toxins and all unlikely. One thing which we always forget is this patient fell into canal with water.
Drowning, pulmonary
Hypothermia. So not only if the patient falls into water or ice in cold country, only this patient will go into hypothermia. All the patients who underwent a road traffic accident because of fluid resuscitation, or because a patient might be exposed and kept in the ER, that itself can cause hypothermia. So don't suspect hypothermia only in drowning cases and all. Any patient can go into hypothermia. Even non-traumatic cases also can go into hypothermia. Okay. So suppose any difference in management in cardiac arrest in hypothermic patients?
You have to give warm fluids and blanket covering.
You usually study the ACLS protocol for managing trauma and rest of the case, but hypothermic cardiac arrest is little bit different. You will have to assess the temperature first. If the temperature is less than 30 degrees Celsius, you shouldn't give adrenaline to the patient. Okay, so patient is in hypothermia. If the temperature is less than 30 degree, continue CPR, because hypothermic patients might require prolonged CPR. So prolonged CPR in the sense more than 40 minutes or so, patient will require chest compression. So you can give chest compressions, you can give bag and mask at 30:2 ratio, and if at all intubated, you can give continuous chest compression. But avoid adrenaline if the temperature is less than 30 degree. Okay. If the patient is showing any shockable rhythms, you can give shocks, but maximum only 3 shocks if the temperature is less than 30 degree. Okay. And along with that, you need to manage the hypothermia also, that because that is a reversible cause in this one. So you will have to give warm blankets or any bear huggers, or any passive and active rewarming should be initiated. And if the temperature is between 30 to 33, then you can give adrenaline, but that adrenaline should be given at double the intervals. Usually at what interval will you give adrenaline? 3 to 5 minutes. That should be increased to 6 to 10 minutes. Okay. So double the interval of giving adrenaline if the temperature is between 30 to 33. Okay. If the temperature is more than 33, then no problem. You can give adrenaline as we manage the other cardiac arrest. Okay. Okay. Then anything else? So this patient was managed conservatively. There was no further SP drop or any hemodynamic instability. His pain also improved with analgesics. Antibiotics was given? Antibiotics, initially count was 8.55 only, so no antibiotics was started. Okay. OTPT is also improved gradually from 90, 205 to 49, 157 improved, 1.99 bilirubin improved to 1.22. INR was normal, 0.95. Okay, so LFT was preserved and improved. Okay. Then hemorrhagic shock, then the classification of shocks. Class 1, there will be not much changes in parameters, only there might be minimal tachycardia.
In that, there will be only less than 15% blood loss. In class 2, there can be, it is uncomplicated shock. It can be managed with crystalloid fluids. It will be around 15 to 30% of blood loss. There might be initial shock indication can be found out by assessing the diastolic pressure. It will start to increase, so the pulse pressure will narrow. So it's because of the sympathetic activity. Because of the catecholamine release, the vascular tone increases and diastolic blood pressure increases.